We would like to thank the editors at BJUI for allowing us to present our study. The background for our study is that the PIVOT trial, which had a median follow-up of 10 years and which randomized men with prostate cancer to radical prostatectomy versus observation, did not identify a prostate cancer-specific mortality benefit with radical prostatectomy versus observation. The hazard ratio describing the association between prostatectomy and prostate cancer-specific mortality was 0.63, with a p-value of 0.09. However, the intermediate and high-risk subsets within PIVOT did appear to benefit from radical prostatectomy, and this is similar to a Scandinavian randomized study in which men were randomized to observation versus prostatectomy. Such men largely had intermediate and high-risk disease, and a benefit in prostate cancer-specific mortality was in fact seen, with a very similar hazard ratio of 0.62, but with a significant p-value at 0.01. Also, in the PIVOT trial, it is important to note that the distant metastasis rate was lower in men who received the prostatectomy intervention, with a hazard ratio of 0.4 and a p-value of less than 0.001. However, because a prostate cancer-specific mortality benefit was not seen in PIVOT, many have concluded that older men with low-risk prostate cancer should in fact be managed with active surveillance and not definitive therapy. Is this right? A careful look at the study design and patient population within PIVOT is shown in the accompanying table. It is important to note that in PIVOT, which was designed to accrue 2,000 patients, only 731 patients enrolled on the study. With such low rates of prostate cancer-specific mortality in the low-risk cohort, both observed and expected, it is likely that PIVOT was underpowered to detect a difference in prostate cancer-specific mortality among the low-risk cohort of men. In addition, among the patients randomized to receive observation, 20% actually received radical prostatectomy or radiation therapy. Moreover, all-cause mortality rates in the PIVOT trial were actually higher than similar rates in the general population of patients with prostate cancer in the United States, implying that men in PIVOT had higher levels of comorbidity than the average man with prostate cancer, and that such men were at higher risk of death due to causes other than prostate cancer than men in the general population. Lastly, it is important to note that men in the PIVOT trial were on average 2 years older than men in the Scandinavian study. For all of these reasons, it is not clear whether the PIVOT trial is generalizable to low-risk patients in the United States. And moreover, it is not clear whether there are specific subsets of low-risk patients that may benefit from a prostatectomy intervention. Population-based data from our group has indicated that among men with Gleason 6 prostate cancer, older men are more likely to die of prostate cancer-specific mortality than are younger men. We hypothesized that the reason for this was that men who are older are more likely to have missed high-grade disease at prostate biopsy, and therefore are at risk of undergrading of their disease. Such undergrading may be attributed to the higher rates of BPH in this population. In a publication by Russo et al. From our group, published in BJUI, cumulative incidence curves that are stratified by age and which depict prostate cancer-specific mortality show that older men are at increased risk of prostate cancer-specific mortality than are younger men, even if they have Gleason 6 disease. With this context in mind, we designed a study using a population-based cohort to determine whether potentially curative interventions such as prostatectomy and radiation improve prostate cancer-specific mortality relative to non-curative options such as observation, and which can include either active surveillance or watchful waiting. We found that potentially curative interventions such as prostatectomy and radiation decrease rates of prostate cancer-specific mortality relative to non-curative options. Age appears to be an important effect modifier of this association, whereas older men are particularly more likely to benefit from prostatectomy or radiation, which can be seen in the cumulative incidence curves from our study shown in the accompanying figure. Potential reasons why our study detected a benefit with definitive therapy, but the PIVOT trial did not, are severalfold. First, our study was significantly larger, given that it included a population-based cohort. Second, our study included men who were generally healthier than men in the PIVOT trial, as indicated by lower rates of all-cause mortality in our cohort of patients relative to that seen in PIVOT. It is also important to note that because we used a population-based cohort that was obtained from the SEER database, which now encompasses approximately 25% of the United States population, that our results may be more generalizable to the United States population at large than the PIVOT results. Our results indicate that men who are older who have low-risk prostate cancer may be at risk for prostate cancer-specific mortality when managed expectantly, and we hypothesize that this is due to occult high-grade disease that can be missed in older patients due to the presence of BPH. Our study suggests that additional screening should be performed in men who are being considered for active surveillance, particularly if they are of older age and even if they have low-risk disease. We would recommend an MRI as well as an MRI-guided biopsy of any suspicious prostate lesions that are seen in older men who are considering active surveillance. An MRI with an ultrasound fusion can also be considered to guide biopsy, particularly of lesions that show restricted diffusion. In such a way, older men who are being considered for active surveillance can be better ruled out for having high-grade disease with potential improvement in the risk of prostate cancer-specific mortality. We would again like to thank the editors at BJUI for giving us the opportunity to present our work.